Wish you a very, very happy International Day for Women. And we are so delighted that respected and dear Chiranjeevi Madam has finally joined us.
Hmm.
She's been a mentor, she's been a leading light and a absolutely huge inspiration for women in ortho. For the longest time, I thought that you were the only one practicing arthroplasty. And slowly but surely, I've discovered these wonderful, bright young women who are also practicing arthroplasty. So it's invaluable, your presence and the guidance that you can give them today for us. So let me share
Yeah.
a small movie. Is it running well?
Yeah, running. Not clear.
I'm sorry, if there's no sound, I'll run it again.
Okay,
Uh,
ma'am.
what do I need to do? Optimize for
You need to share the voice also, audio also of
no,
you.
there is some
Okay.
button. So I'm really sorry the sound was not there. I'll pass it on to the Ortho TV people and maybe they can edit it and run it with the sound later.
Oh,
Voice,
okay, ma'am. Okay.
Voice or Women Orthos in India Collective Empowerment is a group now which is 523 members strong and it's really growing with leaps and bounds. I think the positive effect of seeing role models like Chiranjeevi ma'am and many others are really, really, kind of multiplying in all the medical colleges. So without much ado, I will now set the ball rolling and let's have the first talk in arthroplasty by Mrudhula. I'm going to be a silent spectator because this is not really my subject of expertise, but ma'am will be there to give the expert comments and guide you all. Over to you, Mrudhula.
Thank you, ma'am.
Mrudhula, you are arthroplasty.
I do a bit of everything, ma'am.
Okay.
I'm from Guntur and I do trauma, plasty, scopy, a little of
Okay.
spine.
Okay. You know Amarnath.
Yes, ma'am. He's my mentor.
Okay. Okay. He's my brother.
Yeah, sir told me, ma'am.
Mm.
Are you able to see my screen?
Yes, ma'am. Yes.
Yeah, thanks. So, good evening, everyone. Um, Thank you for this opportunity. So, respected seniors and all my colleagues. So, as an orthopedic surgeon, we all love replacing joints. But to be honest, our goal isn't just placing an implant or a poly, but our goal is to restore function, eliminate pain, and keep our patients moving. Statistics say that approximately 20% of the patients who undergo totally replacement are still unhappy, be it because of the pain or because of the instability or poor alignment. So, most of the people might be thinking that TKA is just a bony procedure. As my boss always says, TKA is a soft tissue procedure and not just bony. And the real challenge arises in soft tissue balancing and achieving ligament stability. So, on this note, I am Dr. Mrudhula and I'll be taking you through the key points of planning and performing a total knee replacement. So I'll be discussing under these heads the timeline, biomechanics, indications and contraindications, pre-op evaluation and surgical technique. So this total knee replacement has traveled over a timeline from way back in before 1950s, where the only treatment option available would be a knee orthodesis, which eliminates pain but at the cost of mobility, or be it osteotomies, where the load is transferred away from the damaged cartilage area, or just simple bracing and walking aids. They give a temporary relief but no long-term effect. And 1950s and 60s saw the dawn of total knee replacement, where hinged knee processes were being developed, but they were rigid and non-anatomic. But this has to be considered the first step towards modern knee replacement. And because they were rigid and non-anatomic, there are high chance of failure, of loosening and wear. Whereas 1970s marked the birth of modern total knee replacement because of the development of various implants, be it cruciate retaining or posterior stabilized, or development of this polyethylene tibial inserts which act as shock absorption, or a shift from constrained to semi-constrained designs. And there was a breakthrough in the biomechanics of the knee, and surgeons realized that soft tissue balance was the key for implant longevity. And 1980s and 90s, there was further knowledge in about soft tissue function and ligament balancing. Implant materials improved. The cement fixation became a gold standard. And there's development of minimal constraint designs. And there was a first attempt at computer navigation. So 2000s is the era of precision surgery, be it because of the computer navigation, robotic assistance, or material advancements, or custom-made implants, or patient-specific implants, or better knowledge about the soft tissue preservation. So to get along with this totally replacement, first thing we need to know the biomechanics. Because biomechanics of the knee and its restoration are the key to improve the functional outcome and also the survivorship of total knee replacement. So here you need to know a few things. One is the mechanical axis. Mechanical axis is a line drawn from the head of the femur to the center of the ankle. The femoral axis will be from the center of the head of femur to the center of the intercondylar notch, whereas the tibial axis will be from the center of the tibial plateau to the center of the ankle. And there is a line dropping vertically downwards from the symphysis pubis, and this is not parallel. They make an angle of 3 degrees. and this joint line is perpendicular to the mechanical axis. Whereas anatomical axis is a straight line drawn along their medullary canals. So here this is the anatomical axis of the femur, and for tibia both the anatomical and mechanical axis overlap. And this depends upon the height of the individual as well as the width of the pelvis. So in total knee replacement, it is important that suppose we have a deformities of the bone, be it because of trauma or it will affect the accurate measurement using an intramedullary guide. Whereas in obesity, it can make it difficult to locate bony landmarks while using an extramedullary guide. And the other important thing you need to know is a tibial slope. It's nothing but the angle, in the sagittal plane, the tibia will have a posterior slope of around 5 to 7 degrees. We draw a line along the anterior cortex of the tibia and a line perpendicular to it and a line along the proximal articular surface of the tibia, and this forms an angle of 5 to 7 degrees. And this is important because in cruciate retaining, it's important to reproduce this slope to ensure satisfactory rollback of femur, whereas in posterior substituting a less slope, excessive anterior translation of tibia. And the other important thing for alignment is rotational alignment is we need to know the three things. One is right side line. It's a line drawn from the center of the trochlea groove to the center of intercondylar notch posteriorly. Then there is a transepicondylar line running between the two epicondyles and the posterior condylar reference line, which is at an angle of 3 degrees with the transepicondylar line. So that is why we have a jig with a 3-degree external rotation inbuilt to compensate for the 3-degree valgus. And the important thing which we need to know the normal biomechanics is a screw home mechanism of locking and unlocking of knee. In simple terms, what happens is when the knee is being extended, that is a person gets up from sitting to standing position, the knee, the tibia rotates externally and it's locked so that we can stand effectively without much of muscle effort. Whereas when the knee is going into flexion, the tibia unlocks and it rotates internally. And this occurs because the medial condyle of femur is little bigger and keeps rolling even when the lateral condyle comes to a halt. And this passive ACL tension will guide the tibia to rotate externally while standing. And the quadriceps contraction will also help in external rotation in the terminal extension. Why is this important? Because in cruciate retaining TKR, a PCL is retained. So there will be more of natural knee kinematics and partial preservation of screw home mechanism. Whereas in PS, the PCL is removed. So the cam post mechanism will substitute for the natural rollback. And there is some loss of natural screw home motion. Whereas in constraint and hinge knees, there is no true screw home motion due to rigid implant design. And what happens if the screw home mechanism is disrupted? There will be poor rotational alignment that will ultimately result in instability and stiffness, and that causes soft tissue imbalance, which will lead to uneven wear of the implant. So the crux of the thing is, the aim of TKA is to recreate normal biomechanical axis and kinematics of the limb. The tibial component is implanted perpendicular to the mechanical axis of the tibia with a posterior tilt, whereas the femoral component usually implanted in 5 to 6 degrees of valgus. Then coming to the indications and contraindications. So the indications would be severe arthritis with or without deformity, or young with systemic arthritis with limited function, or osteonecrosis with subchondral collapse of the condyle, or severe patellofemoral arthritis, or severe deformities associated with moderate arthritis and variable pain. The contraindications, the absolute contraindications are recent knee sepsis, ongoing infection elsewhere in the body, or extensor mechanism discontinuity or dysfunction, or recurvatum deformity secondary to muscle weakness, or a painless, well-functioning knee arthrodesis. These are absolute contraindications, whereas the relative contraindications would be if the patient is not fit for surgery, or if there is severe osteoarthritis of the ipsilateral hip, which should be operated first, because it's easier to rehabilitate a THR with OA knee rather than to rehabilitate a TKR with OA hip. And the other relative contraindications would be atherosclerotic disease of the operated side of the operative leg, or skin conditions hindering the incision, or venous stasis with recurrent cellulitis, morbid obesity, history of osteomyelitis in the close proximity to knee. So all these are relative contraindications. So the pre-op evaluation, you have to get a hold of general medical history of the patient, complaints which are specific to knee, previous treatment history, and we have to take care of the expectations of the patient. And examine the knee joint to find out any coronal or sagittal deformities, be it varus or valgus, flexion or recurvatum. You have to look at the gait of the patient, skin condition, and also previous surgical scars to plan our incision. Look for the range of movement, ligament instability and their correctability, and neurovascular status, and you have to examine the other joints and the spine as well. And the basic radiographs needed are a standing anteroposterior in full extension, lateral view, and patellofemoral view. And a hip to ankle full length weight bearing, that is scanogram, that will give a good idea of the axis and any extra articular deformity. And for templating as well. And in case of any complex primary following trauma, dysplasia, we need to get a CT or MRI depending on the need. Then coming to the surgical steps, I'll walk you through the basic surgical steps of total knee replacement. So the first is the patient in supine position with knee properly draped and prepared with tourniquet on. An anterior slightly medial midline incision is given, and the incision is around 12 to 15 centimeters, 3 centimeters proximal to patella and 1 centimeter distal to tibial tuberosity. Actually, the length of the incision doesn't matter as long as it's giving us a good exposure. And a medial parapatellar arthrotomy is done. And it's important that in this step, you keep an enough cuff of sleeve to the patella so that you get a proper tight closure at the end of the surgery. And the medial arthrotomy is done. Posterior half of the patellar fat pad is removed so that it gives a good exposure of the anterior and lateral aspect of the proximal tibia. And then we create a medial sleeve along the medial aspect of the tibia extending up to the posterior corner, and this medial sleeve will help us in watertight closure at the end. So here you can see this is a medial sleeve being created up to the posterior corner of the tibia, exposing all the medial and posterior aspect of the tibia. And then the knee is extended and patella is everted. The synovium, the fat pad, is excised so that it will effectively prevent the Klunk syndrome. And the patella is prepared. Osteophytes are removed. And then we go on for the osteotomy. So basically there are 5 bone cuts for any total knee replacement. And there is a 6th one which is optional depending upon your implant. The 5 bone cuts would be a patellar osteotomy, preparing the posterior aspect of patella. Then the proximal tibial bone cut, the distal femur bone cut, anterior and posterior condyle cuts, and chamfer cuts. Whereas the 6th cut is optional, where we do a box cut in case of PCL substituting process. So this is the patellar osteotomy being done. Then the knee is flexed and all the ligaments ACL and PCL, depending upon the type of implant you are using, are removed, and the knee is subluxated. So in case of tibia, we use an extramedullary guide. Tibial alignment guide is placed to make the proximal tibial cut, and the depth of the cut should be correspond to the thickness of the implant, that is the tibial tray plus the insert. It's important in this step that you protect the MCL so that you place a retractor and protect that the MCL is not damaged. Then comes the distal femur cut. Here you are seeing the image where the proximal tibial cut is made and the bony chunk is removed. Then going for the distal femur cut, a drill hole is placed in the mid portion of the medial condylar notch, just anterior and medial to PCL. And in this step, it's important that the canal is irrigated so that it prevents the risk of embolism after tourniquet removal. And the stylus will guide the anterior referencing. And at this stage, you can identify the correct rotations basing on whatever lines, the wide side line and transepicondylar line, we can identify that our rotations are in proper alignment. So if you see an anterior grand piano sign in the anterior cut, then you are sure that your rotations are good. Few people do this anterior cut first or the distal femur cut first. I do, textbooks say that this cut has to be made first, but I do the reverse. That worked for me. Then go on with the jig placed on the anterior femoral cut and then make the distal femur cut. So when the distal femur cut is made, you see a butterfly thing or a 8 mark, then you are sure that your cut is good. Then go on with the anterior and posterior condylar cuts with the jig. And the next will be the chamfer cuts in the same jig. And this is a 6 cut which is optional depending upon your implant, that is a box cut. This is done only when you are using a PCL substituting design. Then comes the most difficult part, as I was telling, soft tissue balancing is the key for longevity of the TKR. So soft tissue balancing is done after all the osteotomies. We'll remove all the osteophytes until the anatomical borders, and the posterior osteophytes are removed by placing a laminar spreader. Then the tibial preparation is done. Sorry. Then the trial implants are checked and you check for the patellar tracking. Then the tibial preparation is done and proper bone irrigation is given, and then cementing is done, following which the actual implants are placed, and then you check again for the patellar tracking. Then comes the careful the closure of the soft tissue, first the deep fascia and then the skin. So while checking for the alignment, it's important that in full extension of the knee is absolutely stable. In a little flexion, there will be a mild medial laxity. So those are the surgical steps. So cheers to all the women who heal, women who rise one step at a time. Thank you for the opportunity.
Very good presentation.
Thank you.
It is, you mean only for varus knee. For valgus knee, we go for lateral parapatellar also.
Yes,
That is
ma'am.
a
This is
two-layer.
a yes, ma'am.
This is mainly meant for varus knee, and tight valgus knees where rigid valgus is there. You can go with the lateral parapatellar approach also. But
Yes, ma'am.
that is a two-layer technique, and you have to expose the capsule and you have to release the lateral pararetinacular structures, and you have to be carefully close the cuff. That is a two-layered procedure.
Yes, ma'am.
Excellent. Here we follow, first we take distal cut, entry point same.
Yes,
And
ma'am.
what is your choice of entry? You want to go along with the white side line, or you want to go medial to the white side line or lateral to the white side line? Western people, they keep 7 degrees valgus, so they take medial to the white side line. Here we take 5 degrees of valgus, better to take over the white side line in the center. In the
Yes,
center.
ma'am.
Okay, that is one point. And here we follow, first we take distal cut, and the distal cut has to flush to the notch, and then we go here, subluxate the tibia, and we remove the meniscus and everything, and we go with the tibial jig. Tibia, we take 8 mm on involved side, 2 mm on involved side. If it is valgus, involved side is lateral condyle. If varus, involved condyle is the medial condyle. You all know. So if you are beginner, take the stylus, or if you want to check with your eyeballing, take blade and check the cut. There are different jigs are there where you can place the stylus comfortably, and you can check the cut thickness. And or if you are not comfortable with the stylus, take free blade and check the cut. Check the cut. Never take bigger cut. You will land in mid-flexion instability. Okay, then we take the tibial cut, then scissor and assess the extension gaps. After tibial cut, we assess the extension gaps. Immediately after opening, we remove the osteophytes, we release sagittally in a triangular manner, and we never release more medial collaterals and attain the gaps and see the extension gaps, then keep the sizer. If you take tibial cut, keeping the sizer will be easy. Sizer will be easy. And some sizers like PFC, the posterior condylar pose will be very thicker. It is difficult to put the sizer without taking tibial cut. If you take tibial cut, keeping the sizer will be easy. And if it is an anterior referencing system, you have to be careful. Posterior referencing also, you have to be careful in keeping the stylus for the anterior part of the cortex. And the highest point, suppose if it is coming in between two sizes, be careful. It has to flush to the anterior cortex. Never land in notching. Be careful. So when you are cutting anterior cut also, exit laterally slowly, and suppose if you are in doubt, you have to exit medially. Medially never notches. Slowly you have to come to lateral side. Grand piano sign, if your rotation is good, grand piano sign will be seen. And then posterior cut. When you are cutting posterior cut also, medially you have to keep homons carefully. You don't give medial homons to a very junior or a sister or a brother, because they may not be knowing the collateral position. You have to be careful while cutting the posterior cut medially. While cutting laterally, you have to be careful in protecting the popliteus and lateral collateral. Lateral collateral also will be nearer to the popliteus, just posterior. You have to be careful. And when you're cutting posterior cuts, some people, juniors, they cut tibia also. Be careful, keep it 90 and cut it. And some middle jigs, they will have oblique slopes. So when you have such kind of jigs, be careful while cutting. After cutting posterior, anterior chamfer and posterior chamfer. In buccal papas only, the anterior chamfer and posterior chamfer, we go with the landing mode. Otherwise, you have to go in a regular mode. Anterior chamfer and posterior chamfer. Suppose if you are planning PS, then you have to place your box jig carefully, medially and laterally. In the center of the femur, you have to keep it and cut the box. PFC box will be bigger. Be careful while cutting the edges. In Merrill, you have the advantage that suppose if your chamfers are not so, so proper, you can readjust the chamfers with the box jig. That is the advantage of Merrill jigs. We do all companies in my institute. We do buccal papas, that is gap balancing technique. Merrill, we do. Smith and Nephew, we do. Usually, we are doing 8 companies. Smith and Nephew, Jimmer, Biomet, buccal papas, Merrill. All companies we do in our institute. More of Striker. Robo, we do Striker. Have you addressed all problems, and it is very clear. And second thing, patella debulking you have to do, and the lateral facet you have to keep. Don't damage the lateral facet, and you can debulk the medial facet to little extent. And patellar mall tracking, if it is there, like in PFC, it is common. So you have to be careful. And striker also, patellar mall tracking is common. You have to debulk a little more, and don't touch the lateral facet. It will be in touch with the implant. What are the things, what else you want to discuss?
Yeah, good evening, everyone. Can you hear me?
Yeah, we can hear.
Yeah. Rujuta.
Rujuta.
Yeah, good evening.
Good evening. So happy to have both of you with us. Thank you for joining, Dr. Guruva.
Yeah, sure. It's a pleasure to be with the young orthoplasty surgeons. And I said,
Happy Women's Day.
Yeah, happy Women's Day. It's the appropriate day. And any orthoplasty surgeon is welcome to Sunshine Bone and Joint Institute in Hyderabad to come and learn anytime. They don't need any invitation, any company sponsorship. They just can ring us or email us and come down. We have a visiting fellowships, visiting observerships. We got a virtual fellowships. And so they can come and stay for a week or a couple of days, whatever is that for learning, teaching. We are always open. So please take care of that opportunity.
Mrudhula is working with Amarnath, I think.
Yes,
Yeah.
yes, ma'am. Yes, ma'am.
Still you are working, huh?
Yes, ma'am.
Okay, okay.
So, girls, any other questions for Mrudhula? Or I think all the grounds have been covered. So maybe we'll move on to the next talk by Ravisha Batish, and then both the experts can give her some guidance on that. Yeah, Ravisha, share your screen. Dr. Ravisha is from Delhi, Mrudhula was from Andhra, and Tanvi and Julia in Maharashtra. So now really, I think pan-India, we have enough women in arthroplasty, and that's very heartening. Over to you, Ravisha.
He is Ravisha from Delhi.
Yes, ma'am. Safdarjung Hospital.
Safdarjung Hospital. Okay.
Yes. So, good evening, everyone. And thank you for this opportunity, ma'am. So we're going to start with the presentation. So I took a big topic. I don't know I will be able to do it justice or not, but I will try to cover each and every point and touch each and every point. So the evolution of reverse shoulder arthroplasty and some of the future aspects. So from failure to innovation, the Grimont design and its impact. Now, Grimont initially gave this design, and he pioneered reverse shoulder arthroplasty implants by effectively treating the cuff tear arthroplasty. And then it evolved, the indications evolved from cuff tear arthroplasty to many more. So beyond cuff tear arthroplasty, now it is also being used in proximal humerus fracture or any other rotator cuff injuries, in osteoarthritis, mainly rheumatoid or any other osteoarthritis. So how it evolved? It's mainly the biomechanics which played the role. So Paul Germont, original reverse shoulder, he introduced it. He introduced in sorry. So he introduced in 1980. This introduction revolutionized the shoulder arthroplasty. So he had four key principles necessary to provide a stable construct while allowing the deltoid to compensate for an absent rotator cuff. So first was the center of rotation, which must be fixed and distalized and medialized to the level of the glenoid surface. Second was that the processes must be inherently stable. Third, the lever arm of the deltoid must be effective from the start of the movement, which I will be discussing in the later slides. And then the concept of glenosphere, you can see over here. So glenosphere must be large and the humerus cup small to create a semi-constrained articulation. These were his principles. So you can see this. This is a new process, is a glenosphere. This component fixated over the scapular neck and places the center of this glenohumeral rotation within the bone of the glenoid instead of laterally. So, so Burkhardt gave the concept. So this is the uncoupling of the essential forces. So Burkhardt described the importance of the anterior subscapularis and the posterior rotator cuff, that's the infraspinatus, and the teres minor, working in balance as a so-called force couple. In the absence of the suprascapularis, a functionally intact anterior or posterior cuff can still exert an inferiorly directed force. The inferiorly directed vectors of the force to the center of the humeral head. So it allows the deltoid muscle to power near normal abduction and forward flexion. So if this force is disrupted, and there is a tendency of the humeral head to migrate upwards under the unopposed pull of this deltoid. You can see this, and this results in the shear forces across the superior glenoid cartilage. So he didn't wanted this. So biomechanics, which according to his 4 principles, what he did now, you can see the biomechanics of the native shoulder compared to this reverse total shoulder. This is the deltoid lever arm, this black line. So this is the acromiohumeral interval. When he shifted this center of rotation medially, you can see this, it has shifted medially. Now this deltoid lever arm has increased, and this mainly helps in abduction and the success of this implant. Now, by medializing this center of rotation of the glenoid fossa, Gremont further increased the deltoid abduction moment, deltoid abductor moment arm length, and it improved the deltoid efficacy. Now, these are different. This is an insert center of rotation glenosphere. This is standard, and you can see here it is expanded. So now talking about variations, many variations has come, innovations have come. So increase in the deltoid abductor arm, it happens after medialization of the core. Now Gremont, how it evolved actually. Earlier designs in 1970s, he used these processes which were constrained, and it utilized a fixed fulcrum concept. But they were not clinically successful, and they had to abandon. Then what happened in 1985? Gremont developed a new concept with this glenoid component fixed directly on the glenoid, but the medialization of the core happened relative to the native shoulder. And then came the Delta 3, and there was success in the treatment at the end stage of stages of degenerative conditions. Now, glenosphere designs and scapular notching. So it's a complication. Definitely, when something new comes, it comes with the cost. So what happened? The medial or the lateral position of this center of rotation relative to the glenoid, it was determined by difference between this thickness of this glenosphere, and the articular radius. Now, scapular notching was a complication which was bothering, and this he had to uh, improve it. So the medialization core concept compromising this glenoid base plate fixation, it associated with little poor clinical outcomes. Now then, the humeral head evolved, the glenoid component also evolved, and the stem, he made changes in the stem, which we'll be discussing now. So what innovation came into the humeral component? First, the stem length. It was long. The stem length impacted the implant outcome with a standard stem with a standard length. The stem associated with increased diaphyseal stress shielding. Then he came up with a short stem prosthesis. Now, the short stem prostheses, they're easier to revise and conserve bone stock, but still studies showed that high rates of implant subsidence, and but there was no significant loosening in it. So then later on he came with the stemless arthroplasty, which has been using right now. So this what it did, it avoided the periprosthetic fractures and it preserved bone stock. And mechanical advantages was it reduced the risk of diaphyseal stress rises and decreased the stress shielding. Now with the glenoid component, the main problem was glenoid loosening. It was the most common complication uh, and a result of the failure of this total shoulder arthroplasty. So glenoid loosening, in this retroversion, it was because of the retroversion. So eccentric reaming was done. So this is the evolution from small size to big, and we can even augment the glenoid. We can even augment, and it corrects the retroversion while preserving that native bone. Now, there were innovations in fixation techniques. First, cemented glenoids. Now, cemented all polyethylene pegged glenoids had 10-year implant survivorship, considering the standard for glenoid fixation. Then came the hybrid fixation. Hybrid glenoid fixation combined with the cemented peripheral pegs with a central porous peg for bone ingrowth, showing comparable 10-year survival rate. Now, then last came the base plate fixation with uncemented and with the central screw and the peripheral screw, which we have been using it right now. Now, this is also an innovation. Extended indications are proximal humerus fracture. So, reverse shoulder arthroplasty is now being very widely used in proximal humerus fracture. So, this you can see here it has augmented humeral tray with the reverse shoulder arthroplasty in case of this proximal humerus bone loss. So the biomechanics, so the total reverse shoulder arthroplasty biomechanics, it restored the greater tuberosity shape and increased this deltoid wrapping to improve the stability while increasing this deltoid movement arm to improve the deltoid efficiency. Now, there came design classification. So these designs, these system, they categorize the glenoid designs based on the center of rotation position and the humeral design based on this offset influencing the biomechanics. So you can see the first in this medial glenoid, medial humerus, that means most of the medial positioning of the center of rotation and the humerus. There is the lateral glenoid and the medial humerus. So as the name indicates, the positioning of the glenoid and the humeral components are there. So from 155-degree angle to 135-degree angle, it had evolved. Now here you can see that more lateral humerus position to compensate joint medialization. So this was the design classification system. Now, what are the future trends? Precision planning and execution. Navigation is the future. Patient-specific instrumentation is the future. Now, you can. There are many companies which we pre-plan. We put on the CT scan in the software, and then pre-planning of the implant or the sizing is done, and on operating table, it becomes easy to plan the size and everything so that the complications rate is also less. So now we have convertible implant system that allows revision of an unconstrained shoulder arthroplasty to semi-constrained shoulder arthroplasty without the removal of that humeral stem. So we need to address the complications also, as we discussed, scapular notching and other. So scapular notching, a very potential complication, is being addressed through improving this implant designs and the surgical techniques that we discussed. And there are other complications like instability or infection in the wear and tear being actively researched now with evolving technologies. Now, this is a separate whole together topic, but implant selection, which surgical technique to be taken, and post-op care, these all have to be pre-planned. Now, what is the future trends as we discussed? It has already been gaining the popularity, and minimal invasive surgical techniques with improved implant designs and personalized approach to the patient care. And maybe you don't know, then it's gonna be robotics and AI with the advancements in the biomaterials also. So mixed realities in arthroscopy, it's already there. Definitely, it's gonna come in this arthroplasty, in shoulder arthroplasty. There, when you are doing your surgery and you can see uh, all the implant size of the computer on your lens. And robotic shoulder arthroplasty, it's the new future. I think yeah. Thank you so much.
What is the main indication for reversal shoulder, ma'am?
Ma'am, it is reverse shoulder came up with the main indication of uh, cuff deficient shoulders. So as I explained, in cuff, where there is cuff deficient shoulders, what is because of the pull of the deltoid, the humerus, it goes on it goes on pulling up, and it results in cuff shoulder
Superior migration.
superior. Because of the superior
Superior
migration,
migration.
there will be osteoarthritis.
Yeah, superior
But now,
migration, osteoarthritis, cuff deficiency, and age limit. What is the age limit? Are you can you go ahead with the younger age group?
no,
No. What is the
because
survivorship? What is the lifespan of the reversal shoulder?
it has, as studies have shown, 10 years survivorship. And as what we have been doing, at least 5-6 years have been passed for our patients. So I think 10 plus. And with the new components, even if the wear and tear of the cup is there, we can just change that cup without changing that humeral component. So I think more than 10 years. 10 to 8.
More than 10 years. Okay. Excellent presentation. Are you doing reversal shoulder?
Yes, ma'am. We are doing elbow, reverse shoulder, and hip and knee.
Elbow replacements.
Yes.
What is the company you are using for elbow replacement? I have done 8 or 9 elbow replacements. I used Zimmer and Adler company. 2 companies I did. Link, Zimmer and Adler company I did. What companies you are using for elbow?
So, ma'am, these are local companies, not the Zimmer yet. But for
Okay.
shoulder, we are using Tornier.
Tornier.
Yeah.
Okay. Very good.
Thank you.
Okay, I think what we'll do now is we'll just club both the girls from Maharashtra together so that we have a nice, well-rounded tips from Madam, and then all of you can have an interaction and questions amongst each other. Whatever doubts you all have, also you can ask Madam. So we'll
Thank
start
you.
with Tanvi Shinde, who's from
Yes,
Sangli.
ma'am. Yes. Thank you, ma'am. I'm Dr. Tanvi Shinde, and as ma'am said, I'm from a small town, Sangli, and I do plasty and scopy as well, and trauma. And I'm thankful to Rujuta ma'am for giving platform for aspiring girls like us. She has been doing a lot for girls in orthopedics. So the Varus knees is a big problem. I mean, in our day-to-day OPDs, we are seeing lots of males and more females with such Varus knees. And the problem is not only in difficulty in doing day-to-day activities, they're also suffering, like they are spending more energy in walking, and that is making them having more lung-related problems or even heart-related problems. So their cardiopulmonary function is also getting reduced because of such problems. So the varus deformity we can stage into mild, moderate, and severe depending on the degree of the varus. So 0 to 15 degrees of varus is mild, and then 15 to 30 is moderate, and 30 to 50 is very severe varus. And operating on varus knee starts with the understanding of the pathology of the contracted tissues. So before we begin, let's just understand the anatomy. On the medial side, there are main three layers. So the superficial most layer consists of sartorius fascia. The second layer is of superficial medial collateral ligament and posterior oblique ligament, and MPFL and medial patellar retinaculum, along with semimembranosus insertion. And then the third and the most important layer is of deep MCL and capsule. Other medial structures which contribute to the medial stability are medial meniscus and medial head of gastrocnemius. So when there is severe varus deformity, the medial structures are contracted, which includes deep MCL, pes anserinus, marginal osteophytes, posterior medial capsule, even the PCL. And the osteophytes, which indenting on the medial structures, also contribute to the varus deformity. And most commonly, superficial MCL is the culprit. So challenges that we face in doing TKR in varus knee is managing instability, then management of bone loss, which is on the medial side, restoration of the alignment, balancing of the flexion extension gap, and then we have variety of implants available and how to choose them. So a successful TKR depends on three things. That's a soft tissue balance, medial and laterally, proper bony resection, and you achieve a gap balance which is equal in flexion and extension will give us successful results and a pain-free knee. So achieving symmetrical gap balancing is the ultimate goal in our surgery. So how do we manage a varus knee? So let's see how to go ahead. First, decide whether the deformity is fixed or flexible. Is there any associated bone loss? Whether the deformity is periarticular or extraarticular, and if we need any constraint in this particular case. So release of the tight structures in a varus knee should always be sequential. And after each step, we should check the correction and assess the flexion and extension gap. So the tight structures are released in anti-clockwise manner and top to down, inner to outer layers. I'll just share how. So if you see the knee, the patella is in front. So the release should be anti-clockwise. So starting from the front, so start with 6 o'clock and then go towards the 12 o'clock position. So that's an anti-clockwise. Then top to down. So that's a level 1, level 2 and level 3. And then inner to outer. So we'll see one by one. How I approach my varus knee is I usually do a medial parapatellar approach. Then I go with the medial release. Then I do my bony cuts, and as ma'am said, I go with the distal femur cut first and the tibia next. And then I assess my knee, and if the further medial is released, then I go with that. So finally, quadrant deformity and bone loss management is played when I prepare my tibial tray. So I begin with a medial parapatellar approach and then subperiosteal elevation of the medial sleeve, which includes joint capsule and deep MCL. I continue it till the metaphyseal flare of the tibia. While doing this, Ransal maneuver, that is flexion and external rotation of the tibia, really helps a lot. Then I proceed with the osteophyte removal on the femur as well as on the tibia. As the 10th, the medial soft tissue sleeve and shorten the MCL. As I do PS knee, I release the PCL next. And if you're doing a CR knee, you can preserve PCL, but PCL is also a secondary stabilizer contributing to the medial tightness. After releasing the PCL, I take the distal femur cut and then the tibial cut. Make sure that you are perpendicular to the ground and you are centered in the ankle. And then I check the extension gap. So the extension gap, if tight both medially and laterally, and the patient is having FFD, I cut 2 mm extra from the distal femur. If it is only tight medially, then it requires more soft tissue release on the medial side. Then I prepare. Yes, ma'am?
If you have, distal until like flexion gap and extension gaps are tight, you can take a retibial cut.
Yes, ma'am.
If your extension gaps are adequate and flexion gaps are tight, if flexion gaps are tight and extension gaps are adequate, don't take redistal cut.
Yes.
If extension gaps and flexion gaps are tight, then you take retibial cut.
Yes,
If
ma'am.
extension gaps are adequate and flexion gaps are tight, if you are going with the anterior referencing system, you can downsize the
Downsize
component
the, yes, ma'am.
and you can increase the slope.
Yes. Yes,
Yeah.
ma'am. So then
Sorry.
no, it's okay. Then I take the femoral cut and prepare the femur. Now I check the flexion gap, and if the flexion gap is tight both medially and laterally, I will downsize the femur. And if it is only tight medially, I will release more soft tissue on the medial side. So if the extension gap and flexion gap both are tight medially, we will only require the medial soft tissue release. And as ma'am said, if the gap flexion extension tight, then we'll take more tibial cut. So after doing these steps, if there is still medial tightness, I will release the posterior capsule using a 15 millimeter curved osteotome. It also helps in FFD correction and also increases medial joint space. Again, after doing all this, if it is still tight, then we need to do a stage 2 medial release, which includes semimembranosus insertion and posterior medial capsule from the proximal tibia. If tightness persists, POL is released, and it is best done in figure of 4 position. So now, up till now, we have released till semimembranosus insertion or POL insertion, but we have not touched superficial MCL at all, whatsoever it takes. So even after doing all these things, I'm not able to have a good flexion gap on medial side. I will prepare the tibial tray and I will reduce the size of the tibia and do a reduction osteotomy of the tibia. It also helps in removal of the medial sclerotic bone, and many a times in a severely varus knee, there is a tibial defect which can be taken out by doing a reduction osteotomy of the tibia. And most of the time, this is enough to achieve a good stable knee in a severely varus knee. At the last, even after doing everything what I just said, the knee is still tight on the medial side. We can do a superficial MCL release or a pie crusting of the superficial MCL. So use a laminar spreader on the medial and lateral side and check the gap. If it is tight in both, that is flexion and extension, superficial MCL can be released subperiostally, but I usually prefer doing it a pie crusting way with a 16 gauge needle. And remember the mnemonic, atrial fibrillation.
The shift manner.
Sorry, ma'am?
Z-shaped manner, Nana. Pie crusting of the MCL also, you have to be careful. In a
Yes,
Z-shaped manner, you can puncture with 60 number needle.
yes, yes.
And superficial MCL, it will help in flexion and posterior part of
Yes,
that structure
superficial
that will
help in
help in
extension.
extension.
Yes. So I remember it by atrial fibrillation and pulmonary embolus pneumonic. Anterior fibers are tight in flexion and posterior fibers are tight in extension.
Yes, yes.
So as you can see, the superficial MCL is the most important structure which is affecting both extension as well as flexion gap. Rest of the structures are mainly involved in the tightness of extension gap, apart from deep MCL. So MCL, I try to avoid releasing till the last stage, and if at all needed, I only release it with pie crusting. This was again interesting study published in 2019, which shows the superficial MCL release can open up the medial joint space maximally. So reserve it for the last and try to avoid it as far as possible. This is again ligament balancing in TKR, which has been shown grade wise. So for a grade 1 or mild varus, you can just release deep MCL, medial capsule, and removing all the osteophytes will be necessary, but only required in mild varus knee. If the knee is having moderate varus, you might as well require to release semimembranosus insertion, posterior medial corner, or POL insertion. And only in severe cases you have to release superficial MCL. And very rarely we have to also release or do a pie crusting of popliteus or posterolateral corner to achieve a stable knee. Very rarely in very severe varus knee. So in as I mentioned, with varus subluxation, it is sometimes necessary to release a posterolateral corner to restore the alignment or to achieve a medially stable knee.
Why
So
you want, there is already laxity in the posterolateral corner. The popliteus will be very much stretched out. The lateral collateral will be stretched out. Lateral opening will be there. Why you want to pie crust?
Ma'am, I agree with you, but I have done only once in severely varus knee with subluxation as shown in the X-ray. The popliteus was also very tight. So I had to just release it with pie crusting, but not in many cases. Only one case I have done so far.
Okay.
So what is acceptable? 1 to 2 millimeter of opening on the medial side, 2 to 3 millimeter on the lateral side is acceptable. The femur should articulate with the middle third of the tibia. As ma'am mentioned, many times there is a residual lateral laxity. So IT band is a dynamic stabilizer which takes care of the residual lateral laxity. If you are really worried, you can release more medial soft tissue and use a thicker poly or LCL advancement. But I have no experience about LCL advancement in residual lateral laxity. Most of the times, these cases are also associated with bony loss on the medial tibia. So we need to augment it with the cement or screw, bone grafts, or any augments like uh, tibial tray augments which are available. Many times, if there are bony defects, we have to use extended stem to have a better stress sharing. So that's a different topic altogether. I won't go into the details of these. So is there any indication for constraint in primary knee? So if in very severe varus knee, if you feel after doing the releases, there is medial insufficiency, you may have a constraint, but I've never used a constraint in severely varus knees. So we can very well manage if we are releasing the medial structure serially. So there is not any necessary for keeping any constraints in a primary varus knee. So these are few cases. So she's a 61-year-old lady with a severely varus knee. She was also having a tibial defect and we managed it with the screw augmentation. This is her post-op X-ray and gait. We were able to achieve a good alignment.
With this kind of obesity, better to put a short rod, extension
Okay.
rod, better to
Okay.
have.
Yes,
better
yes.
to have. And you are
I agree,
augmenting
ma'am.
with screws also. The defect
Yes,
is augmented with screws. And
yes,
better
ma'am.
to have an extension rod to have more stability and
Yes,
longevity.
yes, ma'am. If I had to do it again, I'll definitely use a extension rod.
And definitely better to
Yes,
keep an extension rod.
yes. So this is again another lady with a severe varus deformity and a bone defect. So in this case, because she was very obese, we used extension rod in this particular case.
What is
So this
the BMI where you have to go for extension rod?
mostly about 30 we use extension rod, ma'am.
Yeah, definitely,
Yeah.
definitely, definitely. Well done, well done.
This is one more case. This gentleman had a stress fracture with a severe varus knee. So in these cases, using an extension rod, which is well fit in the distal part, can take care of the stress fracture which is associated with the varus.
You went with the CS?
Yes, ma'am.
CS or PS?
PS, ma'am.
PS.
I'm
Okay.
doing only PS, no CR knees.
No, no CR and no CS.
No, no.
Now all companies they are giving with the ultra congruent like deep dish polish. You can go with
Okay,
the CS also.
okay.
Suppose if you have any problem with the PCL, you can go with the CS also.
Okay. I think ma'am Smith and Nephew is providing that mainly
Within
because
is providing, PFC providing, Striker is giving,
okay,
Ortho plus Ortho they are giving.
okay, okay,
All companies nowadays they are giving. And
okay.
rotation, what is the rotation you are taking when your PCA, posterior condylar axis is rotating, and if
Mhm.
femur is internally rotated, what kind of rotation you are taking, how you are calculating rotation?
Ma'am, intercondylar axis. Using intercondylar axis, if there is a defect on the posterior condyle, I usually take
Femur,
the,
femur.
femur, yeah. Or
Yeah,
I manage it with the tibial cut. So according to the tibial cut or intercondylar axis, both can be used.
okay. With
Yeah,
the help of transepicondylar axis, if
yeah,
femur is internally rotated, you can take more 4.5 rotations, sometimes
yeah.
6 rotation also you can take. Now
Yes,
newer instrumentations, all newer instrumentations, they have rotation options also there.
yes,
Previously,
yes,
PFC doesn't have any rotation option. Now
yes.
PFC also have rotation option is there. You can
Okay,
take
ma'am.
4.5, 5 rotations, 6 rotations, 7 rotations, you can take.
But ma'am, what I feel is taking extra rotations, does it make lateral side more lax?
No, 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 never, never,
Okay, okay,
never. It
okay.
will, your balancing will be easy.
Yeah,
Your balancing
that
will
is
be
there.
easy.
Yeah, but sometimes I feel that taking more rotations will make lateral structures a little longer, so it might make the lax on the lateral side.
No, not like that. The jig will have
Hmm.
0, 6 or
Okay,
3, 6. The
okay,
rotation marking will be there. Lateral side,
yeah,
you need to take 6. You
yeah,
can take 3.
yeah.
And medial side, you can take 6. That
Okay,
comes to 4.5 rotation. Then you will
okay,
not have that problem of lateral laxity or lateral posterolateral corner opening will not be there.
okay, okay, okay,
Understand?
okay. Yeah, yeah, yeah.
P6 will be there. You can keep a pin on 6 on medial
Okay,
side and
okay,
3 on lateral side.
okay,
The then rotation will be 4.5 and you will not have that problem of lateral opening.
okay, okay. So, to summarize, soft tissue release should be done sequentially and judiciously. I use anterior referencing and I promote anterior referencing because posterior condyle can be eroded in severely varus knees. Minimum bone resection should be done specially on tibial side and use bone graft augments and stems to offset the stress and use minimum constraint whenever possible. Thank you.
Excellent, excellent, excellent,
Thank you,
excellent
ma'am.
job.
Let's go on to Juilee now.
Oh, all are doing good job.
Yeah, I think these girls, ma'am, they are
Yeah.
really
Uh,
upcoming and bright,
oh,
and I think with the right
all
kind of
heroines.
grooming,
Mm.
you will find many more followers for you.
Yeah. Previously, I was all alone. Now my daughters are there now.
Start, Julie. Unmute.
Is it visible?
Yeah, it is visible.
Okay. Good evening to everyone present over here, and a huge thank you to OrthoTV and WOICE for organizing this talk. So I am Dr. Juilee Mhatre. I am a trauma and arthroplasty surgeon currently working in Navi Mumbai. So let's begin with the topic. Since I've been given the last talk, I think I'll try to keep it short. So let's begin with it. My topic for today is total knee arthroplasty. Is it about the long-term outcomes, or is it just a short-term hype which will be passing out? So to begin with, what exactly is total knee surgery? Total knee surgery is a very common surgery nowadays since all of us are doing it. And the goal from right from its inception to this date, where there have been several innovations, the goal remains very simple. One is to reduce the pain of the patient, other is to restore the function, and finally give them their mobility back. So whatever the innovations are, the goal is always going to be the same. So, and from its inception, we have been doing total knee arthroplasty in a conventional way. There have been many innovations in the implants, cementing techniques, approaches. Then there was computer-assisted surgeries. Then finally, right now, what we're hearing a lot is about robotic TKRs. So what exactly is the buzz about this robotic TKR? Let's try to figure it out what exactly is happening. So in conventional TKR, when we talk about it, we look towards the mechanical alignment. The components are always placed perpendicular to the mechanical axis. We look forward to balancing the gaps in flexion and extension. So eventually what we are looking out for in conventional TKRs is mechanical stability and balancing of the flexion and extension gaps. And all the conventional surgeries are done by instrumentations which have a basic principle, although the companies might have some differences, but the basic principle remains the same. So that is how conventional surgeries have been done, and we are still doing them in the same way. Then when we come to robotic TKRs, and mind you, it is robotic assisted TKRs, not robotic TKRs, because the robo is just assisting us in making precise measurements and helping in taking the cuts. But the brain is still ours, that's the surgeon's. So when we talk about this robotic assisted TKR, what exactly is it? So it gives us a precision advantage. First of all, in the pre-operative stage, when you are planning for the surgery, you can do a CT scan and you can find out if there are any deformities around the knee, or if there are any previous implants, do we need to remove them, or we can get away without removing them. So there is an advantage in pre-operative stage. For one is for all of this planning. And secondly, many surgeons nowadays have come to different alignment strategies. Kinematic alignment, reverse kinematic alignments, functional alignments, everything coming under the umbrella of personalized alignments. So every surgeon has the freedom to decide whichever alignment they think is best for their patient, and they can plan accordingly for the surgery. So those are the two things which are advantages pre-operatively in robotic surgery. And finally, when you're going through with the surgery, you can take precise cuts, like the precision can be brought down to millimeters of values. And even most of the robots right now have haptic controls, so that a lot of soft tissue damage which could be done is avoided because of the haptic control. So those are the advantages pre-operatively and operatively. So until now, we have spoken about conventional and robotic TKR. So we just try to summarize the things on the left side, that is the incision in both is absolutely same. The time taken for robotic is slightly more as compared to conventional for the tracker placement, for registration, for the assembly of the robo. I agree it might decrease over the number of cases you do, but still it is slightly more than the conventional. And when we talk about the things on the right side, precision, alignment, and soft tissue release, because we can decide the amount of cuts, there is lesser requirement for soft tissue release. So all the things on the left side are slightly in favor of conventional, and on the right side are slightly in favor of robotic. So each one has its own advantage. So what is it exactly the game-changing feature right now in TKR, or is it just an additional feature which we are getting? So it's like a debate which could be put up. But eventually, the big question and final question we as surgeons and our patients want is what happens post-operatively. Do the patients feel better after the surgery, better than what we are giving in conventional surgeries? Can they climb stairs without pain? Can they go for a walk in the park without pain? That is what really matters. So there are many studies and many papers. I have not put all of them in this slideshow. But there are a lot of papers which give significant difference in the immediate post-op period, like the knee Oxford score, the knee society scoring, WOMAC scoring, VAS scoring. In the immediate post-op period, maybe due to the lesser soft tissue release or some factor, in the immediate post-op period, it is better in robotic when you compare it to the conventional. However, studies, as I mentioned, one in this slide, studies which are over 10 years or 5, 8, 10 years, all of them mention that eventually after a longer period, both the outcomes of all these scores are equal in conventional as well as robotic. So for the pre-op and the intra-op advantage, does this situation where the post-op is almost equal in both the surgeries, does it can you agreeably say that you should advise this surgery to all of your patients? And then finally, to decide that, because we live in a country where cost is an important and deciding factor, we will move on to what about the cost. So robotic surgery certainly is going to add certain amount of cost to the surgery. And this is a deciding factor to most of the people in our country. So then when we are offering the surgery, the final question which we have to ask is it really a game changer, or is it just an additional support which can be given? So to conclude, I would like to say that if finance is not a problem, if the patient willingly wants to get operated by a robotic surgery, it absolutely is not a problem, because the precision, the pre-operative planning, all are advantages to the patient. So if that is not an issue, I think definitely the patient can undergo robotic. But is it really a game changer where everyone is going to get advantage out of it? I would still be dicey, and I would kind of like to raise a debate about it. If you think about when in Scopy, when we moved from open surgery to minimally invasive via the scopes, it was a game changer. In spine, when you move from open surgery to a mini incision, tubular or endoscopic surgery, you are dissecting less, soft tissue is more preserved. So that might be an actual advantage to the patient. So I think if you talk about game changer, I really wouldn't agree, and that would be up for a debate. So in the end, it is not about the robo, it is about the expertise of the surgeon, because intraoperatively, even if the robo is giving you certain measurements and clinically you feel that the knee feels slightly off or lax, you might change the poly size, or you might
Yeah,
change the cuts or something.
100% correct.
So I think that is up to us as surgeons, and the skills of the surgeons, the experience and the compassion of the surgeon is the main factor, which is to be decided. So I would like to end my topic on that, and I would like to keep it open for a debate. If anyone wants to add on, to ask on, clearly open for the debate. So thank you. I think that was short enough for the last topic. That's it. Thank you. Thank you so much.
Okay. Robotic and conventional. Conventional takes time, not robotic. Robotic is we do in 20 minutes. And robotic placing arrays and all that takes hardly 5 minutes.
Yes, ma'am. When you are used to doing a lot of things, yes.
Robotic is time is less than conventional. Conventional, you have to keep the jigs, you have to see, you have to cut, you have to see the cut thickness, you have to balance and everything. Conventional takes little more time, like 30 minutes. Like robotic, it takes only 25 minutes hardly. Yes, your judgment, your talk is very good. Robotic and conventional, after 6 months, it will be equal. Both are equal. Both scores are equal. And the immediate post-operative robotic is more comfortable than conventional. And robotic is more helpful for the surgeon than patient.
Yeah.
Robotic is easier.
Yes, yes, true.
So,
But it
no,
is necessary to know the conventional surgery to move towards robotic, because
correct.
in case of
Yeah,
anything,
definitely. First, you must,
yes, yes.
you must know conventional what is the problem, how to correct it, how to correct the varus knee, how to correct the valgus knee, how to release the soft tissues, how to get the gaps. Everything you must know before going to robotics.
Definitely.
Without doing conventional, you cannot jump and go to robotics. You will be confused. Sometimes, if medial gaps are very narrow, if it is minus 4.5 or minus 3.5, if you are not able to balance the knee, then you will be struggling with robo.
True, ma'am.
You must have a clear cut idea and understanding about knee before going to robotic. Robotic striker is the best robotic out of
Yes,
all.
ma'am, definitely.
And striker implant also more comfortable to the patient than other companies. Then Rosa, Jimmer also good. But Jimmer is not purely conventional, I mean robotic. Half of the
This is
jigs
the
you have
jig.
to use. Yeah.
You can
Oh, all are
unfold your
doing good
screen.
job.
Yes, ma'am.
So I think really all the girls have performed very well. Arthroplasty, I think, is one of the most highly studied sciences. I think I've been out of touch with it since 1995, perhaps now. But it's so nice to see that despite being only one kind of surgery or something, there is still so much that can be explored in the same thing. So probably just goes to show that if you really want to acquire in-depth knowledge, if you want to really acquire expertise and gain wisdom like Chiranjeevi madam shared with you all, that can come only after years and years of experience. And the more kind of cases that you deal with, the more you learn to address your own faults, the more you learn to accept your own complications. And if you learn out of every learning curve that you go through, I think finally we at the end of the day we can do the best for our patients. And India is a huge country. Longevity is increasing over the years, so we will need more and more arthroplasty surgeons. So well done, keep going. And thank you so much. We only had a 1.5 hour time, and I don't think we even realized how soon that passed away.
Yes.
So,
Yeah.
and I'm
If anybody,
absolutely,
if you want to come to Sunshine, you are welcome.
I think you should utilize this opportunity, girls,
Yeah,
to
Definitely, ma'am. We will love to come.
yeah.
yeah. You can stay with us for 15 days. You can learn all techniques. Already you learned everything. Okay. Just you can see and visit the
Yeah, they
Sunshine
will
for
refine
15 days.
themselves definitely much better.
Yeah,
And
yeah.
absolutely superb. And I'm totally indebted to Chiranjeevi madam to be here today. And hopefully we shall involve you in one of the IOCONs also in future, and hope to be seeing you in person someday.
Okay, okay.
Thank you all
Mrudhula,
the
you
girls
can
for
come to Sunshine.
participating. Thank
Yeah,
you,
ma'am.
Ortho
Thank you.
TV,
Sure.
for always being there as our permanent platform, so to speak. I think women empowerment is not just about us being bold and stepping up ahead or making opportunities for ourselves. Women empowerment is also with the kind of silent support that we get from platforms like Ortho TV and IOA. So thank you so much, everybody. Have a very nice rest of the month. and keep doing the good work that you are doing.
Okay, ma'am.
Thank you, ma'am.
Bye-bye.
Thank you.
Thank you so
Thank
much.
you,
Good
ma'am.
night.
Happy Women's.
Good night.
Okay. Mrudhula, you please give the numbers and names of the girls.
Ma'am, okay, ma'am, sure.
Okay, ma'am?
Okay, ma'am, sure.
If you want to learn robotics, you please come to Sunshine.
Ma'am, definitely I'll plan it.
Okay, okay. Still you are practicing in Guntur?
Yes, ma'am, in Guntur.
In Guntur. Okay, ma'am. All the best. Okay.
Yeah, thank you, ma'am. Thank you
Okay,
so
okay,
much.
okay.
Hello, ma'am.
Hello?
Yeah, ma'am. Can I share the screen for the
1
last
minute.
video?
1 minute. Yeah. Tell me.
Ma'am, can I share the screen for the video?
I think Rujuta ma'am would be sharing video. I think she's left or disconnected probably.
నాన్న వెబ్ సెమినార్